Good afternoon, everyone, and welcome to today's webinar on the use of long axial field of view and total body PET imaging in women's health. My name is William Drew, and I'm joining Juliana Maynard in MDC's National PET Imaging Platform team as PET Engagement and Delivery Manager. This is an exciting and rapidly evolving area where advances in PET technology are opening up new possibilities to image physiology and disease in ways that were never previously feasible, particularly in populations that have historically been underrepresented or technically challenging to study, including pregnant women and those with complex gynecological conditions. Long axial field of view and total body PET systems offer transformative capabilities, dramatically increased sensitivity, lower administered doses, the ability to capture whole body dynamic biological processes. These features create new opportunities to safely study pregnancy, placental function, maternal fetal physiology, and conditions such as endometriosis, where systemic and multi-organ processes are central to disease biology. We're delighted to be joined today by three leading clinicians and researchers who are at the forefront of applying these technologies in women's health. First, Dr. Beverley Holman, who is Principal Diagnostic Nuclear Medicine, PET-CT, and Research Physicist at the Royal Free London NHS Trust, an Honorary Associate Professor at the Centre for Advanced Biomedical Imaging at UCL, will present on her clinical and research experience imaging pregnant patients, sharing practical insights into study design, patient pathways, and the clinical questions that advanced PET imaging can help address in maternal health. Next, Dr. Thomas Wagner, who is a consultant in nuclear medicine at the Royal Free London NHS Trust and a clinical academic at the Centre for Medical Imaging at UCL, will present on his work establishing a UK pregnancy network for PET imaging. Thomas will discuss the rationale for the network, how it aims to deliver equitable access to PET-CT imaging for pregnant patients, and how this network aims to improve scanning protocols and unlock high-impact research. Finally, we'll hear from Dr. Lucy Whitaker, who is Senior Clinical Research Fellow and Honorary Consultant Gynecologist at the Centre for Reproductive Health within the University of Edinburgh. Lucy will present on how novel radiotracers and total body PET could be used to study endometriosis, a disease that is poorly understood and associated with significant diagnostic delay. Lucy will explore how whole body imaging might be able to provide new insights into disease distribution, inflammation, and fibrosis, with implications for both diagnosis and therapeutic development. Together, these talks will highlight how next-generation PET technologies are not only advancing imaging science, but also reshaping how we approach women's health research, moving towards safer, more informative, and more translationally relevant studies. We're very pleased to have you join us today, and we look forward to a stimulating set of presentations and discussion. Just before I hand over to Beverley, I'd like to remind you all to post any questions that you may have in the Q&A box, and we'll try to address as many of these as possible at the end of the presentations. So I'll now hand over to Beverley.
Thank you very much, and thank you for inviting me to come and present to you today. I'm going to be talking about long axial field of view PET-CT in pregnant patients and the work that we've been doing at the Royal Free Hospital. First of all, a little bit about PET-CT imaging in general. So PET-CT is a vital imaging technique for disease diagnosis and staging. It's mainly used for oncology, but it's also very useful for neurology, endocrinology, urology, cardiology, infection, inflammation, and so many more diseases and pathways. It provides metabolic and disease burden information, which you can't get from CT, MRI, ultrasound, or any other anatomical imaging techniques. So without these data, without PET-CT, staging, risk stratification, treatment planning becomes quite difficult and far less precise. So it's absolutely vital that we get PET-CT imaging in these groups of patients. However, PET-CT has been almost completely off limits to pregnant patients, causing a significant diagnostic gap. And that's mainly due to the fact that we're worried about the dose to the fetus in these pregnant patients. It means that this particular group of patients who still need to be staged the same way as everybody else, still need to see disease progression, don't have access to PET-CT. And it can only ever occur if the if the patient's disease is considered high risk or it's very exceptional circumstances. Let's have a look at why this is. So the current RSAC DRL for FDG PET is 3 megabecquerels per kilogram. Now, if we assume a 70 kilogram patient, which is your sort of average weight of a patient, then what we would be doing is injecting 210 megabecquerels of FDG into the patient. Now, the dose from a 210 megabecquerel injection to a pregnant patient, the fetal dose that you would get would be between 0.9 and 3.4 milligray. And that depends on, obviously, the size of the fetus, but also the stage at which the pregnancy is at, so which trimester. CT acquisition as well, because it's a PET-CT, it's not PET on its own, can give a very high dose to the fetus. So published methods say between about 5.7 and 15.8 milligray, giving a total of about 7.9 to 16.6 milligray to the fetus during this scan. Now, those doses are well below any deterministic effects. So deterministic effects are those where above a certain level of dose, something is going to happen, that there will be some changes in the biology, in the risk associated with any changes that we do need to be concerned about. We're nowhere near them. But we do have to worry about stochastic effects. Now, stochastic effects are those where by chance, there is always a risk. So even with the tiniest amount of radioactivity, there's always some risk associated. Now, most of the time, that risk is negligible, and we don't have to worry too much about it. But we can't ignore the fact that there is always a risk. Now, ICRP 84 suggests when you give a dose to a fetus, what kind of advice we should be giving the patient and what consideration we should be giving. So less than 1 milligray to the fetus, the risk is really negligible. And ICRP 84 doesn't advise that we really have to give any extra advice to the patient or consider any extra advice when we're deciding whether or not we can go ahead with the scan. At 1 to 10 milligray, it's still a very low risk, but we still need to start talking about the patient, about the risks involved. Greater than 10 milligray, they still say low risk, but it's slightly more concerning. And we do need to now start considering the risk of childhood cancer. Now, I want to put that in perspective. It's really important that what we're talking about is that at 10 milligray, the risk has been shown to be an extra 1 death from childhood cancer in 1,700. So it's still very low, 1 in 1,700. It's still very low, but it is something we now need to consider. So because of what we've seen up here with the doses that we're looking at for fetal dose, and we know anything above 10 milligray or even between 1 and 10 milligray is not great, we really do only perform PET-CT in extreme cases for this group of patients. In an ideal world, what we would need is for the dose to the fetus to always be less than 1 milligray. And if we are going to do fetal doses, then it always needs to be less than 1 milligray. This is all about to change. So this ability for us not to do PET-CT in pregnant patients is all about to change with long axial field of view PET. So a quick reminder on long axial field of view PET is that standard PET-CT, you get an axial coverage. That's this space here, how much we can actually see of the patient is about 25 centimeters. Depends on the manufacturer, but it's around 25 centimeters. And then it takes about 30 minutes to do an entire scan, because what you're doing is you're moving your patient through the scanner slowly to build up a whole image of the patient. Long axial field of view PET-CT can be about 1 meter in length or more. So they can go up to 2 meters. And our brilliant speakers in the last webinar talked a lot about this. It means that we can image the majority of the patient, or sometimes the whole patient, in one bed position, depending on the length. And it gives a significant increase in the sensitivity of the scanner, which allows us to do both faster scans and have a lower injected activity. It also enables dynamic and total body imaging. And it should be noted, this isn't a replacement for standard PET-CT, which is still brilliant for everything we need that I discussed earlier, but it's an advancement. It builds on the power of PET-CT, it expands the clinical and research potential, and in this case is really promising for using in pregnant patients. So at the Royal Free Hospital, we have a Quadra, which is a 1 meter Siemens scanner. And our standard of care protocol that we use for PET-CT is 1.5 megabecquerels per kilogram of injected activity. We scan for 5 minutes with the patient supine, so lying on their back, and that would give us a fetal dose of about 0.9 to 3.4 milligray. The CT parameters are here, giving us about 2.5 to 4 milligray. So that's what we would get in our standard of care imaging technique to the fetus. But we created this pregnancy protocol, which started off at 0.3 megabecs per kilogram, still scanning for that full 30 minutes you'd get on a standard scanner, and with the patient lying on their side, because lying supine for a pregnant patient can reduce the blood flow to the fetus and is dangerous. So the patient will lie on their side. That gives the dose to the fetus an estimated 0.1 to 0.2 milligray, so well below that 1 milligray, which makes it safe. We then reduced the CT parameters, this going from 65 MAS to 7, and that brought our CT dose assessment down to 0.2 to 0.3 milligray. So this was looking really promising. So we got our first patient example here. This was a 35-week pregnant patient who got PET-CT for breast cancer staging. We gave them 21.8 megabecquerels. So that's in comparison to the average 210. So it's significantly lower. And these are the images that we got out from this patient. So here we have the PET image, and you can clearly see the fetus and the uptake in the fetus that's going on here. And you can clearly see over here from the MIP, the staging that we can do from very clearly being able to see the tumor. The CT, you can see, is not great quality because of how low the dose is, but perfect for attenuation correction and acceptable for localization. So that was great. What we found from these imaging was that we gave the total dose to the fetus was approximately 0.6 milligray, so well below that 1 milligray, which is considered acceptable. We then looked at optimizing this. So we reconstructed the patient images. It was originally 30 minutes. We reconstructed it at 20 minutes and 10 minutes. And you can see that there's not a lot of difference in the image quality between 30 and 20 minutes. The 10 minutes is a little bit noisier, not necessarily as good, but the 30 to 20 minutes is about the same. So it was considered diagnostic at 20 minutes. And because we are concerned about the fetus, we decided instead of shortening the scan, we would simply reduce the protocol from 0.3 to 0.2 megabecquerels per kilogram and give the patient even less activity. Now, in March 2025, we received a request for a patient who had a parathyroid adenoma, and they wanted us to scan this patient with F-choline. Now, F-choline is commonly used to localize parathyroid adenomas. And here I've got some images that show how F-choline has nicely identified this adenoma. And it's usually used where other techniques have failed. F-choline has not been used in pregnancy before. It was never done before. But primary parathyroid adenomas, they're not common in pregnancy, but when they are, they cause hypercalcemia and loads of maternal complications. So nausea, vomiting, arrhythmias, pancreatitis, high blood pressure, preeclampsia, confusion, muscle weakness, bone pain, kidney stones, excessive urination. It is not good for the mother. But just as bad, if not worse, it's really risky to the fetus. They can have a low birth weight, preterm birth. In very uncontrolled cases, there's a high rate of miscarriage. There's neonatal hypocalcemia if it continues, which can cause seizures in the newborn. So we knew that we had to localize the adenoma so that they could perform surgery and remove it and cure the hypercalcemia. The problem is, as I said, but we'd never done it before. So we had no understanding of dose or risk to the fetus. So we had a look to see where choline might go, to see if that might help us determine what would happen. And we found that the placenta concentrates the choline. They take it up preferentially away from the mother. that it's essential for brain development, cell membranes, neurotransmitter synthesis, epigenetic regulation, importantly for memory and neural tube development, liver, muscles, heart, kidney, lung development. So it's really, really important that choline goes to the fetus. So we were worried. We were worried that all of the choline would in fact go to the fetus and provide a very high dose to the fetus. But all other methods had failed in this particular patient. We had no other choice. So the risk from the ionizing radiation, whatever it might have been, was still lower than the risk of not doing it. So we took our 44-year-old, 20-week pregnant patient, injected 17 megabecquerels of the choline, but we only CT'd from the chest up, so that we didn't give a CT dose to the fetus, and we could clearly see that adenoma. So that was brilliant. And then we did a non-attenuation corrected whole body scan for 10 minutes. Here's the image, and you can see the shadow where the fetus is, but clearly no real uptake in the fetus, which was brilliant. And the fetal dose estimated at 0.5 milligray. And they had successful surgery within 6 days and completely removed the hypercalcemia, and mother and baby are doing fine now. Okay, just to give a little quick note on how we determined the dose. So first of all, we got a clinician to outline where we think the fetus was. Then we converted those fetal measurements into meaningful units by comparing them to the liver, which we had on both the attenuation corrected and non-attenuation corrected images, so that we could get an estimate of what we think the actual activity was. Then we used two methods, one from ICRP 128, which does publish dose for small children. We scaled that down based on the fetal weight, and we added the small dose from the mother's organs. We also used Olinda to have a look at what values it got out based on the 6-month pregnancy model, and we combined the two simulations, one for blood circulation and one for other organs. There is further work to be done here, right? The dose to the fetus is not known for the majority of radiotracers, like we didn't know it for choline. We don't know it for most radiotracers. And we also don't know how the distribution will work for different stages of pregnancy. In addition to that, we don't know how the radiotracer distribution changes with pregnancy, because the mother's biology changes as she's pregnant, and there will be different normal uptake for different tracers. Nonetheless, fetal dose is now no longer a major concern, and PET-CT can be performed on pregnant patients when required. And that leads me really nicely into Thomas's talk about how we're going to implement that across the country. Thanks very much. Oh, just to mention the thank you to everyone who was involved, especially Tamar and Jane. Tamar, who did the dosimetry, and Jane, who optimized the CT. Thanks.
Thank you, and thank you, and Pip, William and Juliana, for inviting me to talk about the pregnancy imaging network. So, as you can see on my first slides, collaboration between lots of different institutions, and I'll go into details and explain all of that. So I'll talk first. I'll give some background on pregnancy PET-CT. Then I'll talk about the collaborative network, its objectives, and the support we're getting from BNMS and PIP and industry. So pregnancy has specific pathologies, and the management of disease in pregnancy is complicated and requires considerations of multiple things. So the health of the mother and the fetus, ethics, and balancing the benefit and the risk outcomes for the mother, the pregnancy itself, and the child after birth. It's also a vulnerable moment for pregnant patients with difficult decision-making. And because some diseases are quite rare in pregnancy, especially the ones we're dealing with PET-CT, there's limited evidence on outcomes due to the rarity of presentations. So there's two pathologies that at the moment we're kind of dealing with in pregnancy. The first one is malignancy, and the other one is hyperparathyroidism. So Malignancy is quite rare. Pregnancy is about 1 to 2,000 pregnancies, with most common one being breast cancer, which is about 1 in 3,000 pregnancies. The other most common malignancies are cervical cancer, lymphoma, ovarian, colorectal cancers, and melanoma. The guidelines say that the diagnostic workup should follow the guidelines for non-pregnant patients, so no difference. Oncological outcomes are similar between pregnant and non-pregnant patients, but due to the complications of treatment for malignancy during pregnancy, there can be adverse obstetrical outcomes. And as Beverley's already said, PET-CT has become central to the management of a large number of malignancies. Probably most malignancies are partially managed with the use of PET-CT imaging. Hyperparathyroidism is rare in pregnancy, but can be quite severe. Primary hyperparathyroidism is mostly caused by parathyroid adenoma and can lead to severe maternal and fetal complications that Beverley's already gone into details, with surgery being the preferred treatment. And currently surgery is minimally invasive surgery, so pre-surgical localization has become crucial for parathyroid adenoma resection. And the most accurate imaging modality, especially when other imaging modalities such as MRI, CT, or SESTEMIB SPECT-CT fail to localize the adenoma, is Choline PET-CT. So, as was already said, typically we didn't use PET-CT in pregnancy because of fear of the consequences for the fetus, but that's all changing now with total body PET-CT. So the massive improvement in sensitivity has led to a potential great reduction in effective dose, but we're still in a situation where the patients themselves and the referrers are not aware that we can do really low dose scans. So there's a gap between the reality and the perception of the public, patients, and referrer. Because as Beverley's shown in details, we can deliver sub-millisieverts or sub-milligray dose to the fetus, for which the risk is additional childhood cancer risk and is really very low. So the background risk of childhood cancer is 1 in 500, so that's 0.2%. And the additional childhood cancer risk from the range of effective doses that the fetus is getting is less than 1 in 18,000. So you go basically roughly from a risk of 0.2% to a risk of 0.206% as a result of a PET-CT. So I've been working on setting up a national total body PET network to image pregnant patients. And the objectives of this is to develop a collaborative network, to set up a national clinical service, to use the network, the data we gather, and the expertise at all the centers to develop our protocols and improve them, and to do some research. And we're doing this with institutional support from BNMS and PIP and industry. So why is a collaborative network necessary? It's because we're dealing with patients and clinical situations that are quite rare, with new technology, medical legal risk, and expertise that's required to lower radiation exposure to the fetus and balance that with the image quality. So we need a MP for CT and for PET, nuclear medicine technologists, and nuclear medicine or radiology consultant. And so far, before every pregnant patient we've scanned, we have our little meeting where we discuss the particularities, the indication, and how we're going to deliver the specifics of the scan, with some calculations beforehand from the physicists. So what's the network? So currently there's 3 established total body PET centers in the UK, which are all Siemens Quadra at the moment. Two were funded by NPIP, one in Edinburgh and one in KCL. KCL then bought another total body PET-CT, so they have two, and the Royal Free purchased its own. So there's kind of 3 centers with 4 total body PET-CTs. There's 2 other centers that will open in the next year, so one in Cambridge and one in Manchester at the Christie. So between these universities and NHS Trust, we met or we discussed over emails, and there's consensus agreement to establish a national clinical service and to work together on protocol optimization and knowledge sharing. And we've also discussed with NP, BMS, and industry, Siemens at the moment, and we might talk to United Imaging if we have one of their scanners in the country. So the support will deliver an institutional framework for governance, task group, research communications via BNMS and NPIP, expertise in software development and trying new tools and AI with Siemens, and the network of biotech startups and research institutions via NPIP. So the National Clinical Service, the goal is to deliver equitable access to pregnant patients to total body PET-CT across the UK, were they to need it. The idea is that they will go to their nearest total body PET center. So if you look at the map, it's not ideal in terms of coverage for the UK. We've got 1 center in Scotland, 1 in the north, 1 in the Midlands, and 2 in London and the southeast. So kind of southwest of England, Wales, and Ireland aren't covered at the moment. There's still relatively decent coverage if patients are willing to travel a little bit. And we want to develop nationally agreed indications and referral criteria, standardized protocols, and we want to use our distributed knowledge to learn with cross-center expertise and collaborative learning. And this is kind of the 5 pillars that we're thinking of doing beyond just the clinical service. So in terms of protocol optimization and dose reduction, we want to optimize the acquisition and the reconstruction protocols, improve image quality while minimizing fetal radiation dose. In terms of methodological and technical innovation, we want to evaluate novel tools such as AI-based reconstruction, denoising, motion correction, and enable further reductions in the activity without losing our diagnostic confidence. We also want to generate new evidence to improve our understanding of the clinical indications, the diagnostic yield, and the impact of management of pregnant patients, and build an evidence base to inform guidelines and clinical decision-making in the future. We want to share our knowledge and build capacity as a network and for the future by sharing protocols, data, and best practice across the UK internationally, and support training and harmonization across centers. In terms of engagement and awareness, we want to raise awareness of the safety and appropriate use of total body PET-CT in pregnancy by engaging clinicians, patients, regulators, and professional societies. In terms of potential next steps, so the National Clinical Service, it's been agreed between the 5 centers. So it's just a matter of putting some logistics and details in place. But the things we could do in the future that we're considering is apply for an ethics across the UK for patients that are referred to the clinical service to consent. And if they do, we would then be allowed to share the raw data from their scans for future use, future research, share it across centers for research. Also keep the data about their indications, then be able to follow up in terms of their outcomes. So it would be good to generate new evidence of the role of PET-CT in pregnant patients and be able to share that with the scientific community. Another important step we could consider is a partnership or infrastructure grant to support collaborations. MRC's got some grant that might be a good fit for us. So that's something we'll be looking at in the next year. And we've already talked about international collaboration with Groningen and Copenhagen, who also have interest in imaging pregnant patients and children with total body PET-CT. Now I'm going to talk a bit about the support. So from BNMS, we will probably set up a task group within the BNMS infrastructure, and we can get support for data and protocol sharing by the Professional Standards Committee. And we can use their website, their reach, and their network to raise awareness of the safety of total body PET in pregnant patients, and also to promote the service to referrers. And we're planning to have a web page on the BNMS website where there'll be information about the service, about scanning pregnant patients with total body PET-CT, contact details of each total body PET center, so patients could be referred to the nearest or most easily accessible total body PET center. And PEEP has offered their support for communications around the service via the NPEEP channels, and they could liaise with communication departments at each site. They're going to help with social media content with the case study, promotion of the pregnancy imaging network on their website. NPEEP is also having a tender for an imaging repository and database support in 2026. And once it's operational, pregnancy imaging network would be able to use that. And that would be a great help to collaborate. In terms of development with NPEEP's network of biotech startups, research institutions, there might be opportunities for collaborations, new tools as well. Siemens has offered their support with the two physicists that are based at KCL in Edinburgh to support the service and development in terms of protocol and dose reduction. And they've set up a user meeting for the Quadra just before BNMS spring meeting in Manchester, and there'll be a pregnancy imaging network session there. And so that's kind of our vision, where this network will make the best use of the expertise within the NHS and universities and the support we get from industry and PEEP and BNMS. Thank you.
Great. So thank you very much. So I am not a nuclear medicine specialist. I'm a gynecologist. I'm based at the University of Edinburgh, as William said. And I'm going to talk to you a little bit about some of the work we've been doing on PET-CT and endometriosis. These are my disclosures, of which the only ones that are really relevant is that I've had funding from MPIP and via UKRI, MLC and CSO for this work that we've been doing on PET-CT. So I thought I'd start off by just explaining a little bit about what endometriosis is, because 3 years ago, Endometriosis UK did a big UK survey and about 50% of the population had never heard of it. So it is endometrial-like tissue, so like the lining of the womb, but found outside the uterus. And it's usually associated with significant inflammation. It's not one single disease. We've got 4 distinct subtypes. And so we've got superficial peritoneal endometriosis. This represents about 80% of all disease. We've got ovarian endometriosis, also called endometrioma or chocolate cysts. We've got deep endometriosis, and this and endometrioma represent about 20% of all disease. Deep endometriosis tends to be a lot more fibrotic. There's often involvement of other organs, particularly the bowel, as well as the bladder or the ureter, often called, as patients are at risk of obstruction from this, as well as significant anatomical distortion. And then we can get rarer subtypes like extrapelvic endometriosis, particularly on the diaphragm, but we can also get it in the abdominal wall, particularly after cesarean section delivery. And endometriosis is really common. It affects 1 in 10 women and those assigned female at birth who have reproductive age. It is associated with debilitating pelvic pain. It's the leading cause of unexplained infertility. And people can also get a lot of other associated symptoms, particularly GI and urinary. We don't have a cure for it. Our mainstays of treatment at present are surgery and hormonal treatment, but these are often ineffective. And the direct treatment costs for endometriosis are similar to that of treating type 1 and type 2 diabetes in women in this country. But it costs the wider economy £12.5 billion each year, and that's predominantly due to socioeconomic costs. So 1 in 6 women with endometriosis will leave the workforce because their symptoms are so debilitating. But I think also one of the other big challenges of endometriosis is that it's very difficult to diagnose, and the average individual would experience between 8 to 9 years of diagnostic delay. And that's after seeking help. And actually, many of these patients will have experienced their symptoms for much longer before they first got into a healthcare professional. There is a lot of challenges about endometriosis, so we don't fully understand what causes it. There is some genetic signals, but these are conflicting and don't seem to be the same across different subtypes. There's the disconnect between disease and the symptoms that someone's experienced. So someone can have a single peritoneal lesion and have debilitating symptoms, but equally someone can have very extensive deep disease and actually be relatively asymptomatic. And this disconnect really isn't particularly well understood. And I think also one of the challenges is that we don't understand the natural history of the disease, and it can have varying courses, both worsening and spontaneously improving in different individuals, which makes it very difficult for an individual when they're making decisions about their treatment, not just for managing their symptoms now, but for their future and how this particularly might impact upon their fertility. This lack of understanding of natural history is really problematic. And part of the reasons we have all these issues with endometriosis is that our tools for studying them are extremely imperfect. And that also goes into our issues with diagnostic delay. So if we consider the pillars of endometriosis diagnosis, so as I've said, symptoms don't match the disease. So taking a history from them, examining them very poorly correlates with what disease is actually there. There's a lot of interest in biomarkers, be it salivary, blood, endometrial biomarkers. But unfortunately, whilst lots of candidates have been identified, when these are validated in larger cohorts, they do not then reach the threshold for use as a diagnostic test. So our guidelines are still very clear that we should not be using these to diagnose endometriosis at present. So in terms of imaging, well, ovarian endometriosis can be really easily identified by ultrasound scan. And deep disease, particularly if it's affecting the rectovaginal septum, so between the back of the womb and the rectum, MRI is extremely sensitive for identifying that. But the majority of people have got peritoneal endometriosis. And for that, we know that imaging does not robustly identify that at present. And so then at the moment, our gold standard for diagnosis is surgery. So doing a diagnostic laparoscopy, it's a keyhole surgery to evaluate the pelvis, and then ideally with histopathological confirmation of the lesions once they've been removed. But this in itself, even though it's our gold standard, is not perfect. So aside from the risks of doing surgery and access, which is variable across the country, we know that in some patients, disease will not be recognised. There's also this question of whether or not what the relevance is of microscopic disease is. And we also know that the pathology is not perfect, often from some of the artifact that results from how we remove our lesions. And I think one of the other challenges is that we know that 50% of the people that we suspect endometriosis in who undergo laparoscopy will not have disease. So we're exposing all these people to those risks of surgery when they're not going to have disease identified. And this issue with our diagnostics is significantly contributes to the diagnostic delay. It means we don't understand the natural history. But I think also for me as a researcher, it's very frustrating that we have a lack of objective outcome measures in clinical trials, particularly when we're considering disease-modifying treatments. And also being able to sort of differentiate between different disease subtypes and as well as its biology likely has implications for precision care. And at present, the moment these women and those affected by endometriosis have to cycle through a list of treatments before they finally hopefully get to the one that helps them. And what we would ideally like to be able to do is be able to get to the right patient, to the right treatment earlier on. So what's known already about PET and endometriosis? Well, as you can imagine, with a disease this common, many patients have then gone on, unfortunately, to develop malignancies for other reasons. But as part of their PET-CT workup, endometriosis has been identified, and there's lots of case reports about that. They often are sort of slightly more unusual phenotypes of endometriosis. And certainly when prospective studies have been done evaluating FGG and endometriosis, they've not shown sufficient diagnostic accuracy. But in my mind, this makes perfect sense. So endometriosis can be a very inflammatory, biologically active disease, but it also can be very fibrotic. So if you've got this very active disease, one might anticipate that you would get FGG uptake. But if you've got a more fibrotic phenotype, whether or not this is fibrotic peritoneal disease, or say this patient who's got a big bladder nodule, you can understand why there might not necessarily be much metabolic activity within that. And that's hence why FGG is not particularly useful in these patients. But I think one of the interesting things is that with some of the newer radiotracers that are coming online, these are much more aligned to the pathophysiology of endometriosis. So this is a peritoneal endometriosis lesion. And we know within these lesions, they've got estrogen and progesterone receptors within them. They're very like the native lining of the lining of the womb. And these, there's both estrogen and progesterone receptor-based radiotracers already available. But also within these lesions, we get a lot of information, particularly influx of activated macrophages. And this gives us an opportunity for use of dotatate. We also know that endometriosis lesions express somatostatin receptors 2 and 5 as well within the lesion. But also because these cells have those estrogen and progesterone receptors, they respond to the same changes that govern the menstrual cycle within the womb. And so when you get progesterone withdrawal, you can get microhemorrhage within the lesions. And this results in recruitment of activated platelets. And alongside with the inflammation, you can get further aggregation of activated platelets in the lesions. And this gives us an opportunity to potentially use the radiotracer GP1, which targets activated platelets. Some patients, the disease is much more fibrotic. And then this gives alternative targets for radiotracers. So FAPI, fibrous activation protein, being its target, and then also the radiotracer gallium CBP8, which is tracer target for type 1 collagen deposition, which we get within endometriosis. So I think this is a really exciting time that as we're better understanding some of the biology of the disease, how we can then use some of these newer radiotracers within endometriosis. And I think the other big opportunity is the advent of total body PET-CT scanning. I think we all here will appreciate the benefits of the wider field of view, with both in terms of accuracy, speed of scanning. But I think particularly in this population, and even more so in the talks we've heard earlier today about the pregnant population, it's the reduced radiation exposure. So typically these are a young population, they're planning future fertility, and the implications of radiation exposure is something that is important to them. So there's a lot of interest in PET-CT at the moment in endometriosis, both using using PET-MR and PET-CT, but different groups are using some of the different tracers, and these are just some of the studies globally that are registered. But there are a lot of other groups that are also using PET in endometriosis, but have not got to the stage of registering their studies yet. But particularly, I know certainly in Australia and in America, there are a lot of studies going on, including using the quadra that we're using in Edinburgh, which is what we're doing with our PET endo study. So in this, we started off by doing quite a large characterization exercise, looking at the tracer targets, both in different subtypes of endometriosis, looking at the impact of menstrual cycle stage, and whether or not these patients if they were using hormonal treatments. And these often are used in this population, both as a treatment for endometriosis, but also as contraceptives. And then our first studies that we've done is taking people with known disease that's been identified at the time of surgery and scanning them. And this is really to sort of drill down on the question of, is cycle stage important in the radiotracers that we've chosen to use, and particularly to determine if we need to cycle stage time them. Then the plan is to go on to a prospective study, scanning people with suspected endometriosis just before their laparoscopy to start generating some violent diagnostic sensitivity data, as well as a large acceptability package that goes alongside this, for ultimately wanting to do a much larger diagnostic accuracy study. But what the data I'm going to present now is from this study of patients with confirmed endometriosis, with the key questions of using two different radiotracers. So we're using FAPI and GP1 to identify those two different elements of the more biologically active disease versus more fibrotic. And first of all, we want to say, do these tracers identify endometriosis, and what was the impact of cycle stage or hormone use on radiotracer uptake? So there's two components to this study. The first is people who are getting GP1 in 2 stages of their cycle, so the proliferative and secretory phase. And our patients are having total body PET-CT as well as a PET-MR, just to give some additional dynamic data, but also because historically MRI has been much better for some of the anatomical distortion that we get in endometriosis compared to CT. And then the second component of the study is patients are having the 2 different radiotracers, and this includes people who are on hormones as well as those who are not. And then with that embedded acceptability. So this is some data, it's very early exploratory data, But this is a patient who's got peritoneal endometriosis. So these are the images from their laparoscopy. So this is what we call the pouch of Douglas. There's a space between the back of the uterus and the rectum. It's a very common place to get endometriosis. And this patient's got really angry, superficial, widespread peritoneal endometriosis throughout the pouch of Douglas. She also got a bit of disease on her left uterosacral ligaments, as you can see highlighted here. But this is her GP1 PET. And you can see here we've got quite striking uptake of tracer in the pouch of Douglas. So her uterus is sitting here, and this corresponds to the area that was seen at the time of surgery. In terms of fibrosis, this is a different patient who's got deep endometriosis rather than that superficial type. She's got very fibrotic disease as well, some that is active. And this patient's got really extensive disease, including a bowel nodule. And again, you can see that we've got this here is the left corresponding to the left pelvic sidewall. And we've got tracer uptake. And then in the patients who've had both radiotracers, we can see that we have both fibrosis uptake tracer here, as well as the GP1 signal. And you can see when compared to her laparoscopy, she's got this sort of fibrotic area, but also much more extensive, widespread, more active disease, which broadly speaking corresponds to the differences we see in tracer uptake. So this is very, very exploratory, and this is of patients we know where their disease is, and so it is important we're now moving on to prospective studies. But I think this early data has been really exciting. And one of the unexpected findings we had is one of our patients had diaphragmatic endometriosis, which is incredibly diagnostically challenging. It doesn't show up on conventional imaging typically, both irrespective of CT or MRI. And we can only really identify at laparoscopy disease that's sort of anterior to the liver. So any disease that's posterior to that, we really can't identify surgically without fully mobilizing the liver with all the attendant risks of that. But in this patient, this is their FAPI image. And you can see you've got nice uptake in the area that corresponds to the area that we saw fibrosis on at the time of her laparoscopy. So it's all very exploratory in early days, but our initial data has been really exciting. And what else has been very encouraging is how much the patients have been really enthusiastic about it. I think both avoiding the risks of surgery, the impact on their day-to-day life, and interesting, I think also that the patients were very happy with the concept of serial scans for monitoring, which I think if we were ever going to try and better understand the natural history of disease, that would be hugely important. So there is certainly an unmet need for non-invasive tools to characterize endometriosis. And now that we have these neuroradiotracers, they're much better aligned to the pathophysiology of endometriosis. I think this can combine with the advantages offered by total body PET-CT means that actually we really can start to explore this in a meaningful fashion in patients with endometriosis. But clearly these do need to be followed up by robust prospective studies. So I'd just like to be finishing up by thanking the team in Edinburgh, both our endometriosis team and all those involved in our imaging facility, as well as the funders and our patient support groups. And I'll finish up there. Oh, if it'll let me stop sharing.
Thank you, Lucy. Thank you, everyone. I'd like to thank our three speakers today for their excellent presentations. We've only had one question so far during the presentation. So Thomas, maybe we could just reflect on this question for a moment just to make sure everyone's aware that it's been asked, because it's not just hidden away in the Q&A box. So it's about the training of AI tools and whether we think there's limitations in the training of AI tools in the future for rare diseases, because there's not so much training data that would be available to train these AI models on. So Thomas, I don't know if you wish to comment.
Yeah, I mean, I can just expand on what I've written in the Q&A box. I think it's a really good point to make, and something we need to be very aware of and mindful. But I think in imaging, it depends what we use the AI tools for. If it's kind of generic image improvement, kind of denoising type AI tools, probably it works for all types of pathology, and maybe it's just that maybe pregnant patients have a slightly different distribution of radiotracer because of different physiology. But I would expect if it's about improving image quality or denoising or things like that, it's not because a pathology is rare that the AI tools wouldn't be applicable. If it's something that's more specific than that, or it's not to do with the images, I think that's true that you do need training data that's going to be large enough to be representative and reflective. I don't know if Beverley wants to comment on this as well.
No, I think you covered that really well, Thomas.
Thank you, Thomas. So we have two other questions in the Q&A box. So one's for you, Beverley, on the 18F choline PET-CT. So which simulation tools would help with dose determination and prediction of the impact on the fetus?
I mean, it's very, very hard to have simulation tools for fetal uptake and how things will move through the placenta when it's never been done. So we genuinely, for most tracers, we just don't know what the uptake distribution within the fetus is actually going to look like. So I'm not sure how we would do that with a simulation tool. We can simulate what we would expect the distribution in the mother to be, and then determine what dose we think the mother's uptake will give to the fetus, but not what the fetal uptake will be. I think artificial simulations aren't going to work, but I think what we'll probably do moving forward is try to use small animals to help us have a look at what the uptake might be within a fetus. So I think moving forward, the simulation is going to be not on a system, but by actually using small animals to model it completely.
Thank you, Beverley. We have a couple of other comments. So we have one around using the SCOR guidance for using gender neutral language in imaging for the discussions around pregnancy. I don't know if anyone wishes to comment on that.
Yeah, I mean, obviously, it's very important to make sure that you use the gender neutral terminology. I think if you saw anything that wasn't gender neutral here, that was accidental and absolutely not intentional. And we apologize if we've offended anybody.
Thank you, Beverley. And we have a request for yourself, Lucy, around sharing some of the publications around the endometriosis work that you presented. It's actually piqued interest.
So what I don't want to do is everyone then have all their endometriosis patients turning up at their gynecologist going, I want a PET-CT scan, because we're not at that stage yet. So the data I've showed is of the study that we've still not finished doing all the scans for. We've got another 5 to go before we've finished that piece of work on all the patients who've got confirmed disease. So we're hoping to be publishing that later this year. But in terms of the other data that I presented, in terms of the published data that are surrounding use of dotatate, FAPI, and sorry, I've just done 2 presentations back to back. I can't remember if I did show some pictures of the presentations about the publications, but there is published work on FGG and a case study on FAPI and the somatostatin.
Thank you, Lucy. So we have a couple of others that have come in. So one that's in the webinar chat. So given the potential for very low dose in total body PET, do you think that serial FDG scans at various times in the menstrual cycle could help? Has that been done already?
I suppose if that's with respect to endometriosis, I think that probably is targeted at me if it's menstrual cycle. I think FDG hasn't worked for endometriosis in the past when it's been looked at, and I think that's because the disease is often very fibrotic. So I'm not sure that doing a piece of work at looking at FDG at different cycle stages would necessarily change its sensitivity for endometriosis. But I think it is always a really important thing to consider. I think the other thing to say for the impact of menstruation, because most patients will get a degree of retrograde menstruation, if you've got a tracer that's going to have been anyway affected by blood, you do not want to scan them when they're actively menstruating, because you'll have a lot of extra deposition within the pelvis itself. So that makes the scans really difficult to interpret.
Thank you, Lucy. A question that's potentially directed at yourself, Thomas. So what would be your guess of the total number of PET scans that would be needed annually in pregnancy? So I'm not quite sure the context of that. Maybe
I think, I mean, the way I understand the question is how many pregnant patients we will need PET-CT annually kind of in the UK, or I'm not really sure. I mean, my guess is that it would probably start to be small numbers, but once the awareness spreads through the community that it is safe to do these scans, I think it will increase. It's still relatively rare situations, either malignancy or hyperparathyroidism in pregnant patients. I mean, there are other potential conditions, so vasculitis, for instance, that might affect pregnant patients, for which PET-CT might be helpful for management. But my guess would be less than 10 per center to start with. At the Royal Free, we have scanned 5 patients in the last probably 18 months. I can't remember exactly when we scanned the first patient, probably 15 to 18 months. So that's roughly for a year, 1 per quarter. I'd guess even if numbers increase and awareness increase, I'd say probably less than 10 per year to start with, and then might grow a little bit, but still a rare condition. So it's not going to overwhelm services.
Thank you, Thomas. So we've got one last question. So I believe this is probably for you, Lucy, because it probably links into the global study distribution that you presented at the end. So considering that the PET-CT study is shown in your presentation, do you know if there's any plans to expand the research into Latin America?
So I think it's really important when definitive diagnostic accuracy studies are done that they are multinational and a lot of work is done to ensure inclusivity. The studies I've presented globally are the ones that are registered. I know there are definitely other people who are doing PET-CT studies who just have not registered them. So I think, there may well be some studies already taking place in South America. But I think it's important when these larger studies are done that we do ensure that the results of them are generalizable.
Thank you very much. So I think we'll draw things to a conclusion there. I would like to start by thanking our 3 presenters today for their excellent presentations. They've obviously stimulated a high level engagement with the questions that we've had. I'd like to thank the audience for joining us today in this webinar, which is focused on the use of next generation total body PET for reshaping how we look at and approach women's health research. And I look forward to you all joining us in the 3rd webinar of this series, where Professor David Newby of the University of Edinburgh and Dr. Jason Tarkin of the University of Cambridge will discuss non-invasive in vivo thrombus imaging in cardiovascular disease. And the details of that webinar and the registration links are all on the MPIT website. Look forward to seeing you then. Thank you very much.